Thank everyone for staying. I appreciate it. I know it's getting late. Everybody's getting tired, coming down off the wine buzz. So, like you said, my patient had exertional compartment syndrome. She received a fasciotomy for that, and it's. I just want to describe the management and describe some of the outcomes based on this. So compartment syndrome, a little background, it can be a traumatic thing and it can also be a chronic thing. And in this case, it was a chronic condition and due to overuse. And so it's really seen in military personnel, high-level athletes, avid runners. In this case, my patient was an avid runner. So compartment syndrome can occur in different parts of the body, but it's most commonly seen in the lower leg and most commonly seen in the anterior compartment of the lower leg. So the lower leg contains four major compartments. You have the anterior, the lateral, superficial, and deep posterior. And then there's actually, in some of the research I came across, there was a controversial fifth compartment that has housing the posterior tibialis. So you may see that in some of your future research, causing some problems in the back of the leg. So the anterior compartment contains some very important structures. The anterior tibialis muscle, extensor hallucis longus, extensor digitorum longus, anterior tibial artery and vein, and then also the deep peroneal nerve or deep fibular nerve. So basically, all these structures are surrounded by a fascia, and that fascia is very inextensible and it's very inelastic. So when pressure rises in there, it really doesn't have any give, and that can really cause a lot of problems. So when it compresses some of the nerves, they'll get, in extreme cases, foot drop, as in this case, and also they'll have numbness and tingling, a lot of pain. And so she experienced all of these. So for the physician, the gold standard to diagnose is a Stryker intracompartmental device. What they do, it is an invasive procedure, and they'll stick a needle into the problematic compartment. And so what they do is they have like criteria, and they'll take one pre-activity, they'll take one post-activity. And depending on that criteria, they'll say that they have a favorable diagnosis for exertional compartment syndrome. So for my patient, she actually had positive findings in both lower extremities. The left lower extremity was the only one that was actually symptomatic. The right lower extremity had a higher pressure reading, but she wasn't symptomatic. So at that time, they decided to only operate on and do the fasciotomy on that left side. So obviously, surgical decompression can be one of the options, and it's been found to be. There's a range of different studies that I looked at, and 78 to 92% of those studies, in those studies, they were able to return to their prior level of function. And so for an avid runner, military personnel, or the people who are predisposed to getting this is like the only thing that they're going to do. You're going to have a really hard time stopping them from activity. And conservative treatment really is cessation of activity, taking anti-inflammatories, stretching, and these sort of things. So really, it's not really an option for someone who's a high-level athlete. You're not going to tell them to stop doing what they do. But there was one study, very recent, 2015, that came out as a retrospective look at 10 patients. And so what they did was they employed a 4-foot running strike. And it's a lot of people when they run, at least I know I do, you'll get like a heel strike, if you can see. You have the concentric movement of the anterior tib, holding it isometrically, and then you eccentrically load the anterior tibialis. So for this population, what they ended up doing was having them do a 4-foot strike, where they're only landing on that 4-foot all the way throughout the running cycle. And so really what it does, if you think about it, it stops that eccentric contraction of the anterior tib. And the anterior tib, the eccentric contraction, is what really has been hypothesized and theorized to actually cause a lot of the increased pressure. So in this particular, it was a case study, retrospective look. So all 10 patients, I think it's worth noting that they were able to actually avoid surgery. And this is something I wanted to try but wasn't able to do, as we'll talk about a little later. So exactly my patient, the patient history, she was a 34-year-old female, an avid runner. She came to physical therapy after the fasciotomy, had lower extremity pain, a lot of muscle weakness. Her motor control was decreased. She couldn't walk or run for long distances. And she presented to therapy about 3 weeks after the surgery. So in her history, she told me she had a history of numbness and tingling, a lot of pain that got worse with exertion. And she started, this went on for about a year. And so at, I guess, the end of that year, when it was at its worst, she really started to experience foot drop when she was walking. And this was within less than a mile. And so at that, rightfully so, she went and saw the physician, and they ended up scheduling a fasciotomy. Her major goal was to get back to actually compete in a marathon in October of 2015. So as a student, I've never seen this, and my CI actually really had never worked with a patient like this either. So I went and looked at a lot of the literature and tried to find something to guide me, and really there was nothing that, except for some case reports out there, but really there's no literature on this. And so there was one proposed rehab protocol that came from a DPT at the University of Wisconsin, and it's something that I felt like it was a good framework for me to follow, something I could use. And it's intuitive. It's an intuitive protocol. It's 4 phases. That first phase was rest and getting back range of motion. The second is getting into the light strengthening phase, and then they kind of move into more of a strengthening phase, and then finally more sport-specific activities. And I guess the real major downfall to this was that it wasn't based on a patient per se. It was just all based on tissue healing time. So you have to kind of take it for what it's worth. But it also, I feel like this is a good protocol for any patient. It kind of made sense to me. So for my patient, phase 1, I feel like the initial healing phase really kind of already took place. I didn't see her until 3 weeks after the surgery. So we did do some manual therapy, passive range of motion, joint mobilizations in all planes, some nerve glides to try and get the nerve running through there, and also some soft tissue work, scar mobilization, as she complained of some pain around the scar. And she responded very quickly to the manual therapy, and by the 3rd visit, she really had full range of motion in the ankle, and she was doing well. We also worked on, in that beginning phase, like wall squats, some light ankle, hip strengthening, stuff like that. And it was really necessary because her squatting mechanics were terrible. And when I told her to squat, it was like this, and then back. And so we worked a lot on this. And by the end, she did a lot better with that. So visits 4 and 5 coincided really with about that light strengthening phase that I was talking about. We did some open chain stuff to begin with, but then quickly moved to closed chain exercises and a lot of focus on her hips, as she had a lot of hip weakness. A lot of balance work was also done on the Bosu ball. A lot of squats and lunges, side steps, as you can see in this picture. And then we quickly progressed to single leg balance, and I really wanted to work on single leg balance as she wanted to get back to running. You need to be on a single limb at all times when you're running, and also to really improve her proprioception. So. Again, like I said, a big focus on that hip, knee, ankle alignment, and really focusing on her reducing that knee valgus and maintaining a good neutral pelvis during all of her mechanics and while she's running and everything that she's doing, really. And phase 3 was visit 6 through 8. We really progressed the strengthening exercises. This is where we implemented like a walk-jog progression. And the walk-jog progression was 1 minute walk and a 1 minute jog. We started about 7 minutes. On the treadmills, and we started as a warm-up, and then we quickly added it to her home exercise program, and she really wanted to get back to running, and this was something that she was really wanted to get back to running a marathon. So I educated the patient at that time. I said, in a lot of the literature out there, it's pretty widely accepted that about 10% each week you want to, you don't want to go more than 10% each week in your distance that you run. And that's even with someone who doesn't have a pathology. At visit 7, she was doing this at home. She was doing about 2 miles, 1-to-1 walk, jog, no symptoms, a little bit of fatigue, but that was to be expected. And then by visit 8, she came back and she had ran 2.8 miles, and she did like a 1-to-2 walk jog, and that was not what we talked about. That was not part of the deal. And so as you see, she came back to me and told me that she was experiencing numbness and tingling, and she had pain in the right anterior shin now, and that's the one that had the increased pressure to begin with. And so at that point, I told her to go see her physician, and what she did, and she came back that 9th visit, and she said that she had scheduled surgery for another month out for that right side. And so I gave her a general, lower extremity strengthening, flexibility program for her to do pre-op and post-op, so she could until she came back to PT. The outcome measures that I used, I did the low extremity functional scale, foot and ankle ability measure, girth measurements, single leg stance, 6-minute walk test, goniometry, and manual muscle testing. So for the LEFS, she started at 76.3, and she ended at 100%. 100% is basically no difficulty with any lower extremity function. That did meet the minimal clinically important difference of 9, and her foot and ankle ability measure was also at 100% no difficulty. I think a lot of the case reports used this and said this was a good tool, but in this case, I think since I saw her 3 weeks after surgery, it really didn't prove to be a good tool for me. But it did show that she had control of her ankle and she did well. Single leg stance, eyes open, was within normal limits bilaterally at the end, and her eyes closed actually got worse. It decreased by 8 and 7 seconds. So then I was like trying to think like why, and I'd realized that I didn't work on eyes closed balance, so it's probably my fault. I wanted to blame her, but I couldn't. Also, girth and range of motion were actually normal compared to the other side, so it was great. The 6-minute walk test may seem weird. I was just trying to, it's really a test for aerobic endurance, but I really just wanted to see, could she walk X amount, and then at a later date, could she walk more, and what happened. So I thought this would be a good test to use. There's no normative data for me to compare it to, but for what it's worth, she did walk about 200 extra feet, and she had no pain as compared to the beginning where she did have some pain when she was walking. So, and her manual muscle testing, she improved for all muscles from baseline. So to conclude, really, the rehab of the left lower leg was effective, so it worked, but it really wasn't, not without the right leg becoming symptomatic. And so I kind of reflected on that a little bit and asked myself a few questions. And the first one was, should there have been a bilateral release initially? Should she have gotten them both done? And it's really, it's between the surgeon and the patient, but I did look up some studies and I wanted to see if there was anything available. And there was a case study of 15 patients, and long story short, they all had bilateral release, and they were all satisfied. They would recommend it to a friend. That's what it said. And so it could have been an option, is my point, for her. And as she told me at the end, she was really kind of upset with the fact that she wanted to get back to running this marathon, and she now has taken a huge step back. And so I think that would have been something for her to look at. The other thing was was my therapy too aggressive? Were we doing too much too soon? May have been, not sure. And then the last thing I asked myself was, would it have happened anyway? And it's again, I looked into some of the research, and they say that about 75–85% actually, if it occurs on one side, it's going to occur on the other side. So it may have happened anyway. Some of the limitations to the study, to the case report, sorry. I didn't, like I said, I kind of alluded to this. I didn't see her till 3 weeks after surgery, so maybe if I saw her earlier, we could have made some differences. And then I didn't have the ability to try that 4-foot strike. We had discussed it. I was excited to try, and she had heard about it before, but we were unable to do that as she self-discharged because she had had other surgery. So, and finally, this is the case report design. Obviously, it's one patient. This could be a unique result. So that's all I have. Do you have any questions about the case report?
So you brought up that study about 4-foot striking.
Yes, sir.
Talking about the eccentric component of it,
Mhm.
causing that component, so like the syndrome of it. Did it say anything about any of the, like how big the concentric part of it was, like the foot clearing, like running? Did it say anything about
Yeah.
how?
And I wish I had a better handle on the actual 4-foot run, because it's fairly complicated to learn. Apparently, it takes time. But I know that you're landing on the 4-foot, and you're actually using the hamstrings a lot more to pull your foot up, and so it's a little bit different. You're not using the anterior tib as much as well with the concentric portion. But I don't know the exact mechanism of it. That's a good question. Yes, sir.
In your research with compartment syndrome, did she have any history of back problems?
That's a really good, that's a great question. It really is.
Why not?
I think that was very insightful because she did. She had back pain.
She does have history.
She did have a history of back pain.
Did you look at her back in any way?
Actually did.
Good for you.
She complained.
Well, you gave her neural tension stretches. You gave her neural tension.
Yeah.
Why did you do that?
It was a lot to really, for the lower extremity, to just get the nerve moving through, but it wasn't to actually assess the back. It wasn't what I was using it for.
Did she have neural?
But she had a little bit, but it wasn't really a problem at that time. But she had a history of the back pain. She really did. But we weren't working on it at that time. She said, I have back pain sometimes too. She said, my IT band hurts sometimes. She had bilateral hip dysplasia as a child and a few other things. And we were trying to just work on one thing at a time. But she didn't complain at that time.
So you had said she had weakness in her hips.
Mhm.
Did you find anything in the literature about a correlation with weak hips and the need for fasciitis?
Not really, actually. I think it's just more of a mechanical thing. And in my opinion, just looking at her mechanics, and I kind of showed you how her squat was, and I think it can just wreak havoc on your biomechanics in general and cause problems. But I didn't find any specific research that stated that, no. Yes, Frank.
Have you found, just reflecting back on her case, would there have been anything that you could think of that you would have done to protect the right side? Like, would it have been, would there have been any protective measures you could have done
Yeah.
to the other side?
I think I was kind of saying that how like I saw her a little bit late. I think I would have tried to educate her early on maybe not. I think she was using that right side and really dominating on that side, and I think I would have tried to have alleviate that some. Also, again, the forefoot strike, like I said, I wanted to try to alleviate some pain there, but that's all. Yes, Chris.
It seems like you ran into some ceiling effects on the outcome measures that you used,
Mhm.
and then kind of the other ones include like going to mattress and neural muscle testing. And I was trying to think of one that I would use, but it's difficult because she's coming from a surgical point, which is also such a high level runner, so it's hard to find something that encompasses both ends of that. I don't know. Is there anything that you thought that you would have used instead?
Not outcome measure wise. It was really just looking because her goal. She wanted to get back to running a marathon, and that's what I wanted to get her to do. So I was kind of thinking, how distance that she can go without pain, and how. But a specific outcome measure, I'm just not aware of one that I could have used. But that's a good question. I'm not sure.
Hey, Robbie, did she have any vascular issues with the compartment?
She did not actually. Yeah, it was just on exertion, and there was no other complications with it.
Is there any indication that any kind of like deep myofascial release type work has any effect at all on compartment syndrome that you ran across in your research?
Yeah, so foam rolling, I sort of mentioned it, like stretching and foam rolling,
Right.
really trying to really get at it. It didn't really have a great effect. I think it was, in the short term, it can be useful, maybe as a preventative measure I saw, but once you're starting to experience this, it didn't have much of an effect. Any other questions?
Thank you very much.